Welcome to the Sandwich Generation Podcast, a resource for adults balancing the dual responsibilities of raising children and caring for aging parents. Whether you're helping your parents downsize, explore real estate options, navigating caregiving, or looking for practical advice to help your family thrive, this is the place for you. Join us as we bring you expert insights, heartfelt stories, and actionable items to support you and your family within this unique generation.
We've come a long way from care, Sarah.
Oh my gosh.
I know. Well, that's what I was going to ask. Is that how you guys know each other, from Manor Care?
So we kind of grew up together, me and Sarah.
That's fun. We had our kids at the same time. We both left Manor Care and went to these smaller companies that was an adjustment for both of us. And so, we just used to grab lunch and be like, what the world, what are we doing? How do we do this? Having all this structure, and then all of a sudden we were having to figure out our own structure. It was just interesting. So,
yes. Oh, that's funny. Yeah, you went from corporate to small business entrepreneurship.
Yeah,
kind of thing. Yeah. Startup. Yeah, that's fun. Well, I was doing a little research on Grace at Home, and it sounds like a great company. In fact, we were talking about that last week, Sarah. The how visits to doctor's office is going to change into more house calls. But we should, before we get into it, do some intros, right?
Yeah. So we should introduce our guest today, which is Sara Landrigan from Grace at Home. We kind of just shared how we know each other, but give us a little bit of your background, Sarah, if you don't mind, and we'll just jump right into all our fun questions.
Sure. So thank you again for having me. So once again, I'm Sara Landrigan, and I am actually not from Indiana. I was born in Buffalo, New York. So I'm a diehard Bills fan. I love Josh Allen, and moved here in 2000 with my now husband, who had went to IU. So he was from Buffalo as well, went to IU, started working once he graduated, and I moved out here after I graduated. So started, like Sarah said, at Manor Care, just doing admissions and sales and not really having a clue what healthcare had to offer, and just kind of rolled up our sleeves and jumped in. So worked the skilled side, worked rehab, worked long-term care, assisted living. And then I was a regional for a little bit, and I started, I got pregnant. And so people would say, how are you going to travel? And how are you going to do this? And I would say, I'm a career woman, and my husband's going to have to pick up the pace and take care of the baby. And then I can remember crying, holding her, I can't leave her. So
that's funny.
I went back into the building, and then I had my son, and I got really selfish, and I wanted to only work part-time, and Manor Care didn't really offer that. So
nope.
I had known Tammy Browning, who is the founder of Grace at Home, and she was seeing patients and doing all the community outreach and all the sales and marketing. And I said to her, what do you think about hiring a salesperson part-time? And she was like, I don't know. I always do the sales. I don't know if I want that. And I said, well, what do you think? And she said, well, let's give you a shot. And I said, okay. So 11 years later, I'm still here, and I'm not part-time.
Nope.
It's just been the biggest blessing for my family and for me and my kids, and their mission and what they do is so amazing. And the way that we work is just, I can't say enough good things about this company. And even though we have gotten so much bigger, we've been able to keep just where the heart of Grace at Home is, which is very faith-based, growing through God's grace and being able to treat these people to live what they want. What do they see for the rest of their lives, and how can we just be a small part of that and help them achieve that? And it's, like I said, I feel just so blessed to be a part of it. So it's been really good. So I don't plan on going anywhere. They're going to have to kick me. I'll probably die here.
Hey,
that's you've got the resources if that's what you want to
do. Yeah, that's true. This is
what a great story. That's fun. She took a chance on you, and that's great.
Mm-hmm.
Yeah, it's working out. It seems to be working out.
Yeah. she would always say, I don't want someone that sells. Like, Tammy was huge on like not over promising and under delivering. And she was afraid a salesperson would get out there and say, we can do it all. And, so it was very personal, so it was just a great fit. So yeah, that's
amazing. Well, we have been focusing on talking about all things that come with aging in place for the last few weeks and kind of focused on that for the month. And that's why I was like, okay, we need to have, Grace at home or someone that can talk about having these in-home primary care visits. Used to know about house calls and doctors that visited the home all the time way back. Well, we don't know this, but it was, we see it in shows and movies.
Yeah. In the 1800s.
Yes. Yeah. Things change.
We're called the 1900s now.
I know. My kids refer it. Like, were you born in the 1900s?
I know. Mm-hmm. It's terrible. What do they say? Like the oldies is now like Dr. Dre and Snoop Dogg. Like that.
Yeah, don't mess with
Dre. Oh gosh, yeah. But no, I just think there's a lot of people that don't even know that this is an option for them. And since we're talking about aging in place and staying at home or whether it's downsizing and staying, to age in place, a lot of people are doing that as well. So I just thought you'd be a great fit to kind of talk about what those services are and educate our audience, which is primarily we're focused on educating the adult children who are helping their parents age. So in the aging process. So we thought you'd be a great fit to talk about that. So kind of just tell us a little bit about what does Grace at Home do? How does it work? All the little nitty gritty things about that.
Sure. So Grace at Home basically is just primary care house calls. So we see patients in their homes for primary care. We have nurse practitioners and physician assistants that do the visits, and they are overseen by 2 physicians. And they go into the home and just really get down to bare bones with these patients. A lot of them haven't been to a doctor or go to a lot of specialists, but don't have one hub doctor of primary care to really pull it all together. So when our providers go into a home, they really they look at everything, every past medical history, every medication that they're on. And on average, an initial visit is roughly 1.5 to 2 hours to really to see what's happening with these patients. And there's just so much now that we can do in the homes for these patients. And I think the hardest part about this is people are living longer, mm-hmm. right? So, and they don't necessarily want to leave their homes. Right. So, and the kids, it's a lot of dynamics there because some of them feel that guilt, where they want to do whatever mom wants, but it may not necessarily be what's best for mom, so someone that is, it's hard for them to get to the doctor, and it's hard for them to really understand what's happening. Going to a doctor's visit, getting them up, getting them dressed, getting them in the car.
It's a full day.
It's a full day. And by the time mom gets home, she is beat, right?
Mm-hmm.
Yeah.
Sometimes they're only in that doctor's office for maybe 20 minutes.
Yeah, I was going to say 2 hours that you just said versus a 15, 20-minute visit is, that's
it's
huge.
Crazy. And when you actually see how a patient lives, so when you go to a doctor, you can show them what you want them to see.
Right.
But in their home, maybe they don't tell the doctor that they have 10 cats and, but that's not explaining why they're sneezing all the time. Right. It's so when you get in their home and you can actually see how they live, it uncovers a whole multitude of other things that come up that we can help with.
So you guys are psychologists and social workers, and
we do it all, girl.
Yes. Nice.
And people don't know where to look for resources,
right?
So they ask us a lot of times, and we have been so lucky to have such great partners to reach out to and try to get them connected with. We couldn't. It is a team effort, right? Between like home health or hospice or,
Yeah.
workers, anything. I mean, there's a lot happening inside these patients' homes, and it's a full-time job for sure.
Yeah.
You might have said it already. How many nurses did you say you have?
So we have nurse practitioners and physician assistants. I think right now we're at roughly 17.
I was going to say, you must stay very busy.
We do. We serve about 2,500 patients in the Indianapolis and surrounding counties.
Wow.
Yeah. So we have a pretty large footprint. We are Marion County and all the surrounding counties. And then we go as far north as Lafayette, and we go down to Columbus. We have a couple facilities in Bloomington that we service. And we are looking to expand with another assisted living by the end of the year into Ohio and Michigan. So,
wow.
Oh, that's great.
So it'll be fun.
Yeah. Well, so how are there like certain qualifications that an individual has to have be able to have a doctor come into the house? Like, what's the rules or regulations? Can it be anybody? Do they have to be like homebound?
So years ago, it used to be homebound. They had to be homebound in order to qualify for our services, but Medicare lifted that quite a few years ago. So now anyone really can be seen by us, but we restrict it to like home limited patients because we try to be very careful on who we see. Obviously, elderly population, but someone that can drive and can go to the grocery store on their own and can go get their nails done and go get their hair done can easily go to an ambulatory primary care doctor. So for, just for continuity of care, we do try to limit it to like that home limited patient because that's truly what the need is at that time.
Okay. Yeah, no, that makes sense for sure.
We will also take care of like the caregiver. So if there is like a husband taking care of his wife and he's able to drive and he's able to go to the store, we will still see him for
that's great.
care.
Oh, wow.
That's the caregivers to still get, a lot of times they don't take care of themselves because they're taking care of their loved one.
Absolutely.
So we'll sign them on as a patient as well and see them.
Oh, that's so good. Great. Yeah. The caregivers are often putting off their own appointments, as we know, to take care of who they're taking care of, and then their health deteriorates. So that's great.
Yes.
That's really good to hear. So you said that you can bring in like all kinds of different, you have resources and that kinds of things. So are there things that you can bring in, like say someone needs a x-ray, are there things like that you're able to bring into the house and do, or do they still have to go?
No, we can do x-rays. We work with companies that do ultrasounds, blood work, lab work. We can do all of that. Obviously, like podiatry. We have resources for all of that can come into the home. So they don't have to.
That's right. Yeah. If there is something that you cannot provide in the home, do you have resources to help them transport if they need it to wherever they need to go?
So normally it just depends on the patient and if they're able to get into a car, if they need a wheelchair van. But yes, we can work with different resources to get that set up for them. Now, normally the family will get that set up, or if they live like in an assisted living community, they have a transportation bus normally that will be able to take them. And that's what's kind of neat is it's really evolved. So when I started almost 11 years ago, we saw mostly patients in their private homes. And so now, though, we also see it's kind of flipped where we see 60% like in an assisted living and then 40% roughly in private homes. So we still do the private home, but we are able to do assisted living, independent living, and then brick and mortar private home.
That speaks to, Jean Ross, Primary Record. She just posted something about it, doing a time study for nurses in senior communities because they're so stretched thin. And then last week, we had
Jen Adams talked about how much home care they're actually providing in community,
inside of a community.
It's a lot. It's a lot. Staffing in the facilities is tough right now. I think it seems like no one has ever recovered since COVID, to be real honest. the burnout from that has just
continues to trickle. We're seeing that. Yeah.
Wow. Yeah.
Yep.
Yeah,
Some
so
people completely
need
left like the nursing field just because they couldn't handle it anymore.
Mm-hmm.
Wow.
I'm one of those people.
Sarah.
Sarah.
It's me. Yeah. I was like, oh, okay.
Seniors just in a different capacity. And
I know. That's the thing. I'm just not in the healthcare capacity, but I still love my seniors and still get to work with them. So it's kind of worked out. Yep. Oh. How about, so you said you can collaborate with like other doctors or other specialists that they're seeing, that kind of thing. So when you are seeing a patient in their home or in their community setting, do you automatically send information to their specialists that they see, or do they still keep a general practitioner that's outside of you guys? Like, how does that work?
So it just depends. So for specialists, yes, we get all of that information up front. And so in every patient's chart, we have what's called like a care team. So when the provider does a visit, they can auto fax that note right to that specialist. A lot of our providers will do like peer-to-peers with like the cardiologists or the oncologists, because sometimes it's just like they're going out for a follow-up on a new medication. And they want to see how they're doing. But if the patient isn't up to it, my NP will talk to the doctor and just say, everything looks good. Are you comfortable prescribing for another month or whatnot? We're not replacing specialists. Like, that's definitely not. We are strictly primary care.
Sure.
But a lot of people do have a primary care doctor that they've gone to for 20 years.
Yeah.
And they're like, I'm not giving up my physician. He knows me, and we're like, that's fine. So under Medicare, they actually are allowed to go see that primary care doctor every 6 months. So that's the biggest thing, is just making sure that it's following like Medicare guidelines. If they have a PCP, we will send them visit notes. But if they're going to that primary care every month, we definitely need to see them, right?
Yeah,
right.
But in an assisted living, a lot of times they can sign on with us for like PRN only. So they may have a doctor in the community that they see, but maybe they call us if they had a fall and they just need an x-ray ordered, or they think they're getting a UTI and they just need some lab work done. We can address like those acute needs, and then we will send all the updates to their primary care doctor so that they know what happened as a follow-up.
Seems like you're getting, like more continuity of care. It just seems like they're going to be seen more regularly by having you guys there and being able to provide some of the stuff that they probably would put off if they had to go somewhere to do.
Yes.
Yeah.
And that's a lot of times we'll get referrals from those primary care doctors because they're like, this patient continues to cancel their appointments.
Yeah, that's what I was going to say. That would be a great referral to you guys when they're consistently missing their appointments. Yeah.
Yep. So we can see them in the home, and then, they can still follow them once a year or twice a year if necessary.
Okay. And then the patient still feels like they're being loyal to their primary care physician that they've had for 20 years. Yeah, that's great. And you're sort of acting as a liaison between, in some cases, it sounds like, right? Between the primary care physician and you all, and a supplement.
Yeah.
Or and a supplement. Yeah.
Yeah. The specialist. Absolutely. For sure. Yep. Yeah.
More hands on the patient, like more eyes on the patient. Our whole goal is to keep them aging in place at wherever they call home and helping avoid like those hospitalizations. So we don't want them using the ER as their primary care doctor. We'd rather have them call us and try to keep them at home and treat them.
Maybe now would be a good time to just pause and go to our commercial.
Losing a loved one is never easy, but having a plan in place can bring peace of mind. That's where Indiana Funeral Care comes in.
That's right. Whether you're pre-planning for yourself or making arrangements for a loved one, Indiana Funeral Care offers compassionate, affordable, and personalized services to honor every life in a meaningful way.
And they don't just handle traditional funerals. They offer cremation services, military honors, and even customized celebrations of life, because saying goodbye should be as unique as a life lived.
With locations in Indianapolis and Greenwood, their team is here to guide you through every step with care and respect, so you can focus on what matters most, your family.
Visit indianafuneralcare.com to learn more about pre-planning options and how they can help you create a beautiful farewell for your loved one.
Indiana Funeral Care, because saying goodbye should be about love, not stress. So Sarah, you were mentioning like Medicare isn't going to pay for them to go see, a primary care doctor and you guys every month kind of thing. So what insurances, do you guys take all your normal traditional insurances? Can people private pay? Like I know concierge doctors are a big thing right now. So how do you get paid?
So we bill Medicare Part B, and then they're secondary. And then obviously if they have an Advantage plan, we're in network with most Advantage plans out there. And we're also in network with Medicaid too. If someone doesn't have insurance and wants a private pay, yes, they can absolutely do that as well. But that's like the cool part about it is we go to the home and it's still covered under insurance.
Yeah.
So that's a huge question we always get is how much is this going to cost? And so we're
Right.
like, the exact same as it's going to cost if you go to your ambulatory doctor. So there's no extra charge for having us come to the home.
Yeah, except you don't have to use your gas and your time to drive there. So, really, if you calculated all the costs, it might be a little bit less expensive.
You're saving money. You're saving money.
There you go.
And it sounds like getting way more face-to-face time with your provider too.
Yes.
So.
Yes.
Wow.
I really like what you said about just you get the full picture when you can be in their house and see really how they're living, all the nuances. Do they have an adult child there living with them, sleeping on the couch, all day, or all of those things. I say that because I had an experience where I went to somebody's house to talk about downsizing services, and there was, an adult child sleeping in the other room that, just sort of, if we would have just talked over the phone, I wouldn't have gotten that.
Right. Yep, exactly. Yeah, no, you definitely see the full gamut of what's happening with the patients when you're there. And I think that's the one thing I always love about Grace at Home is when I was coming on board and I asked, Tammy, like, how long do we spend with a patient? And she said, as long as they need.
Wow.
So, now we do try to limit our visits to like 30 to 45 minutes. So maybe it is only a 15, 20-minute visit. But for some people, the kids are there and the family's involved and they have a lot of questions.
Right.
So we want to make sure that they're comfortable with what we're doing with their parents or for them. And, if that means we always give like a 3-hour window of when we're going to be at someone's next appointment, because if we get caught up with one, we don't want them ever feel rushed. So we always say, your appointment will be between 1 and 3. And then that way, if we do get behind with another family, it gives us time to get to the next one.
Sure. Catch up. Yeah, that was going to be my next question. How do you balance that? Do you call them beforehand and say, are you going to have a lot of questions? Do you have an adult child there trying to gauge like how long each appointment's going to take? That would be a heavy lift. But yeah, give them a window of arrival. That's good.
And once you get to know the patients, like the providers know. Like they're like, just get some extra time because I know they're going to have a lot of questions. And so they're very involved in scheduling, that appointment and how long it takes. So.
Oh, Lisa and I are very familiar with that. I definitely know some of the folks when I go, I'm like, okay, this is going to be at least a 3-hour, appointment kind of thing. Yeah. We're going to be there for a while.
Our initial appointments are typically 2 hours also. Yeah. So that initial consultation, just getting to know them. But
what about technology, like any sort of new technology innovations, things that you're using in the house? Like I know back when I was in home care, a lot of patients were having to check in through the phone and do like a weight and their blood pressure and things like that. Like, are you guys able to help with those things, utilize services that are more on the forefront or innovations that you feel like we should be aware of that are coming down the road?
Yeah. So we actually do use remote patient monitoring.
Okay.
It's very much that. It's like we set the patient up and we give them a kit, and it has a scale, a blood pressure cuff, pulse ox, thermometer. We can even use like a Dexcom for diabetic. And then there's actually this new item coming out with, it's like a pill box, and everything is Bluetooth enabled. So we have a system, and basically as soon as they step on the scale, it automatically uploads that weight into our system. So they don't have to call in. It's all through an app on their phone. So they would just open that app, step on the scale, and their numbers come straight to us. Same for yeah. And the cool thing is, like, for the new pill pack that's coming out, it basically tells you when that med box is opened. Now, obviously, we can't tell if they take the pills or not.
Yeah, sure.
At least, like, if it's not opened, we can see, oh, Mrs. Smith has not taken her morning meds yet, or her pill box hasn't been opened yet. So we maybe call and check on her. So there is a lot of really, really cool things that we're able to use. And with a lot of our assisted livings, they can use this equipment as well, and it automatically uploads into their EHR. So then instead of like a nurse having to walk around and write everything down and then go put it in every patient's chart, they just walk around with their phone or a tablet that we provide them. They walk in the patient's room, they press on their name, they do all their vitals, we get it, and they get it. Automatically uploads into their chart.
Oh, that's great.
Yeah. So
EHR, just for those that's your electronic health record. So people that don't know what that means. I have found myself using a lot of acronyms on here that I'm like, oh gosh, I have to make sure people know what that means.
Yeah.
Forget.
Yeah.
Yeah. I had a question in your initial questionnaire that we sent. We asked what are some 2 or 3 key messages or insights that you'd like to share with the audience, and you gave some really great ones. One of my favorites is having the difficult conversations up front about care. Tell us more about that. Is this, you were talking, I'm assuming, about your company, but also about families having difficult conversations, like maybe caregivers with their loved ones, or tell us more about that.
So I think a huge part of what we do is like advanced directives. It's one of the first conversations that we have with people, and it's amazing how many don't have their advanced directives in place. And so like the post form or their DNR forms, really cutting down like what if they were to code, like what do they want to have done? And I think people don't like to talk about that. That's a really
It's not a fun conversation. What is, for the audience, what is a post form?
I don't actually know what it stands for.
I looked this up. Sarah, we totally looked this up a long time ago.
Yeah, I used to have to use it in home care. So physician ordered scope of treatment.
Yes, there you go.
Yeah.
It basically tells like if they want to have chest compressions, if they want to be on tube feeds, if they want or if they just want a do not resuscitate, like what do they want?
Sure.
Yeah.
Yeah. And then the other thing that I really liked, well, they were all great, but be your own advocate. And you talked about this generation. So I'm assuming seniors they trust their doctors specifically, but they need to know that it's okay. And it's important to ask questions and maybe even push back, because we're the only ones who know our bodies. I mean, nobody else knows our bodies like us, right?
Right. And people are, that whatever the doctor says is gospel, right? Like that's what they think, so if something is wrong, and we encourage the children to do it as well, push, ask a lot of questions, making sure that they know that if they're not getting what they want from this physician, it's okay to go talk to another physician to get a second set of eyes.
Sure.
And I think people, it's just a natural thing that they don't like to push back. They don't like to, that's what the doctor said, but you have to be your own patient advocate. Cause I've seen so many times people getting led down the wrong path because the doctor is a little too, blasé, and they'll say, oh, sorry, it's just because you're 90. Well,
right.
that's not necessary. I mean, Sarah, when we worked at Manicure, like we had 103-year-olds that were walking around like they were 70, so.
I remember that about Manicure. Manicure always had the hallways were buzzing. I mean, that was one of my favorite communities. People were, the hallways were buzzing. But yeah, and I mean, I think it gets uncomfortable for people sometimes to push back, or to ask questions to their doctor. Sometimes, it's intimidating, and the doctors are so rushed, and it's not anything bad, necessarily about physicians, but it's just important to ask questions and be curious for sure.
And I think we even see that at Grace at Home, not all of our providers are a perfect fit for every patient.
Right.
And so it's like if we have some providers that are a little bit more laid back than others, and it's okay to have a different provider lay eyes on that patient and try to like maybe come up with some different what's happening. We have a really cool Teams chat with all of our providers on it because we see so much in the homes, and they'll throw it out there like looking at a patient that has A, B, C, D, and E going on. I've tried this, and this, and I'm like, boss, what else do you guys recommend? And then everyone can kind of, because some of our providers have specialties in like cardiology. Some of them have worked psych in the past. So we have such a huge mix of providers, what their experience are, that everyone brings a little bit something different to the table.
So they can leverage everyone else's expertise. That's great.
Yeah. Collaborative, and don't let I think, I don't know, maybe I shouldn't say this, but I think sometimes some of the physicians can kind of let their ego get in the way and just aren't open to hearing other suggestions for their patients, or admitting when they may not know what the best step is, the next step kind of thing. And so I think that's great that they can be collaborative and bounce, run ideas past each other.
And sometimes, like, just we were talking about having difficult conversations, like that kind of goes back to that as well. I have some awesome providers that are very comfortable sitting with a family member and saying, I know you love your mom, like, and I know like you want to do what you think is best for her. I feel like here are your options. You can go down this path, or you can go down this path. And maybe it's time to go like hospice, like comfort measures, like she's not going to get better. And those are, once again, those hard conversations that we're not telling them what to do, but we're showing them. I mean, there are some physicians that just operate all day long. That's not always necessarily like what is best for the patient. And I think that's just one of the things I love about Grace at Home is we truly try to do what the patient wants, but also what is best for the patient. And right or wrong, that's how we've always kind of practiced.
Yeah, I like that. Yeah. And I mean, the tough conversations do include, telling a doctor that, I'm going to get a second opinion, or, and some people, I would say they just don't have those conversations and just sort of, goes to one doctor and go over here. Well, it would be helpful, if we were all advocating, or if we had somebody to advocate for us, to have those conversations that just people are afraid to have and maybe are not having.
Yeah.
And there's a lot of good resources. I mean, there's a lot of people that don't have family or family's not involved.
Sure.
Right? That's where we reach out to different like care navigators and care managers that can be that advocate for those patients. And they're out there, and there's so many good ones that you work with that you kind of know, I'm just going to call this person because I know that they're trustworthy and they're going to truly do what's best for the patient. So it's just another resource that's out there that you know about.
Sure. Yeah. When you were talking about advocating, I was thinking about my grandma, because that's how I got into this niche, this real estate niche of serving seniors. Not only is it difficult conversations, but at some point, and this was the case for my grandmother, her health had just declined so much. She just did not have the energy to advocate for herself. She just didn't have the energy. And even at that point, someone still needs to be advocating for people. So that's good. Yeah. Good stuff.
I feel like we've covered most of my questions. I guess, obviously, if people are here locally and they want to learn more about your services, Sara, they can go to graceathome.com. But
there's dashes
website?
in between
dashes in between
each word.
Dash, and the word @home.com. Yep.
So grace-at-home.com. Got it. Okay. Yeah. Any other questions you have, Lisa? Or I guess we always ask too, like one piece of advice you could give to families or adult children that are advocating for their parents. Like what's your best piece of advice to give them?
Gosh, I guess I would just say, be present is the best piece of advice I can give them, because there's a lot, even for people that are in like the facilities and stuff, there's a lot that goes on. These people are getting a lot of mail from like these Advantage plans. Sign up for the service. This isn't covered. Or they're getting calls from people saying, your identity's been stolen. I mean, there's this new text going out, like you owe money for tolls or things like.
Yeah, I got that.
I got that too. Yeah.
So I think the biggest thing for these kids is just be present, talk to your parents, and listen to them, because I see a lot of kids come in and they try to like take over. Just be present with your parents, but also remember that they're people, they are still your mom. Like they don't necessarily, we don't always know what's best for our parents. We think we do. And we do what we do because we care about them and we love them. But sometimes we just have to accept that this is mom and this is how she is. And no matter what, like this is how she's going to be, and just be present, and especially like the ones with like dementia or that are starting to go down that path. There's so many groups out there that can help educate you on how to handle a patient with dementia, correcting someone or telling them, remember, mom, I told you this 10 times already. Like that's not, just learning. We're never too old to learn. And I think that's the hardest thing is just, be present, listen, do what we can for them. They sure did everything they could for us. So, and I know that's not everybody, but I mean, if you're able to be present and you have the relationship, just, meet yourself and really look into so many of these great resources, because there's a lot to offer.
Mm-hmm. That's really good advice, because we are talking, our audience is adult children who are managing a lot. They're raising their own families. They've got their own careers. Sometimes they're out in another state than their parents. And so it's really easy to be like, here's how I would do it. Here's what we're doing, but just taking the time to just set everything down for a minute, put your cell phone down, look at your parent in the face and have a conversation with them and figure out what it is that they want and really actively listen to them. That's great advice.
Yep.
Yeah.
And ask for help.
A great place.
Yeah. We surround ourselves, like I always say, I surround myself with like a village of people that if I need help, like I can say, can you help with this? Like, it's okay to ask for help. We don't have to do it all ourselves. Like, let someone feed our kids one night so we can go hang out with them.
Sure. Yeah. Our kids would probably prefer that anyway, right? I mean, and they get to a certain age where they really don't want us around, even though we feel like we need to be. Before we go, we always forget this part, so I'm not going to let us forget it this time. So Sara and I are with Indy Real Estate Experts. We're a real estate brokerage in the state of Indiana that specializes in helping seniors downsize, and we're the title sponsors of this podcast. So we want to make sure that we're growing this podcast so we can help educate as many adult children as we can. So be sure everybody to like, share, follow, comment, stream, download, all of the things to help build our podcast so we can educate as many people as possible.
Yeah. Thank you, Sara, for being here. And we just appreciate your knowledge.